I'm Dr. Mila Brujic, and welcome to this episode of the Optometric Insights Show, where we're joined with Dr. Damon Dierker, and we're going to be talking about OCTA and differentiating dry from wet. Dr. Damon Dierker, welcome and thank you for joining us on this episode. Appreciate you. For somebody who is in the optometric space and who has literally had their head under a rock for the last 20 years, please introduce yourself and tell us a little bit about your background.
Dr. Brujic, fellow class of 2002
Two.
optometric graduate. I've been Damon Dierker. I'm in Indianapolis, Indiana. I am a partner in an ophthalmology practice. We have 7 locations, 3 surgery centers, and we really focus on refractive cataract surgery. And then other service lines I'm involved more heavily in. I run our dry eye clinic and have all the bells and whistles there. I do a lot of things in glaucoma and retina, and then I manage our 500 plus doctor referral network as my day job. And then my night job, similar to you, Dr. Brujek, we're doing all sorts of things to engage with colleagues across the country, and doing something like this podcast is one of the things that makes optometry so great.
You are truly an individual who's practicing at the highest level, Damon. And it's actually one of the reasons why I'm so glad that you're here with me talking about this topic and such a timely topic for a few reasons. One, as a co-business owner, you know the value of increased reimbursement for procedures that we're performing that more accurately represent the time and effort that's being put into these. And there is a new code for OCT angiography at this point, 92137, which certainly does provide some level of justification for investing in performing the test. But more importantly, it's the clinical aspect. And you've always been one that's incorporated technologies very, very quickly. So with OCT angiography, tell me how you're leveraging it, what your standard protocol is for those patients who are coming into your practice and have macular degeneration.
Yeah, so I've had the technology in various forms for the last 7 or 8 years. The latest technology I have with the Solix, I've had for about 6 months. And my protocols haven't changed a whole lot, even with the new code. Is if I suspect that somebody has either too much blood flow or not enough blood flow, and the only way I can assess that patient accurately is with OCT angiography, I'm going to order that test. So in patients with AMD, I'm concerned if a patient's at risk for developing choroidal neovascularization, I want to catch that as early as possible. So yes, we can use our standard macula OCT, but that doesn't tell us anything about blood flow. The only way we've been able to do blood flow in the past is traditional fluorescein angiography, but now we're using our existing OCT units with a software upgrade to be able to look at such exquisite detail, the retinal circulation, to say, is someone have normal circulation? Do they have circulation where there should not be blood flow? Or in the case of someone with diabetes, maybe they have ischemia, and we really can't pick that up with other technology. So for my AMD patients, especially those with intermediate AMD, these patients that have drusen and RPE changes that are at higher risk for developing advanced disease, OCTA is something that's being done typically every 6 months for that patient because it's going to tell me information I cannot get in other ways.
It is remarkable. When we first had spectral domain OCT, we thought, wow, this is an amazing step forward. And then, or excuse me, time domain, and then spectral domain was a massive step forward. And I thought, boy, this can't get any better than this. And the scans just kept getting more detailed. And then with OCT angiography, it really changed the game because of the different slabs that you can look at and the inner layer of the retina, the outer layer of the retina, and where we expect to see vasculature, like you were saying. So, Damon, share with us what you're looking for in the AMD patient, and then let's jump into a case where OCT angiography helped change the trajectory of how you manage the individual.
So for AMD patient, I think most important thing as an optometrist is we have to have the confidence to make the diagnosis for a patient. It can't be, oh, you're just starting to have this, or I think you might have this. Is do they have macular degeneration or not? So once we've made that diagnosis, and how we make that diagnosis as well described, is then we have to have a plan for a patient. And in my practice, I really want to stratify, are they early, are they intermediate, are they advanced? Because my treatment for that patient is going to differ. So the case that we'll talk about is a patient I've seen for a while. She's 80 years old now. I diagnosed her with intermediate AMD years ago, and that means that she has either some large drusen in her posterior pole or some drusen with RPE changes. In this case, she has a little bit of both. So these patients are at higher risk for progression. So what I've done for years is I actually do genetic testing for these patients to understand what is their risk based on their genotype of progressing, and is there anything that I can do to mitigate that risk? And there are some patients, it's a little bit controversial, but there are some patients that we believe if you give them high dose zinc as a supplement, that may actually be detrimental to them, and that's based on their genetics. So I did genetic testing for this patient that I diagnosed with intermediate AMD and found that it is safe and appropriate for her to take her AREDS2 supplements. So she's done a good job. I see her every 6 months. She's coming in. This is just a couple weeks ago, actually, Mila, on this patient. No real complaints. I'm here because he told me to come back. Her vision is stable, 20/25 ODOS. She's got a little bit of a cataract, not yet surgically necessary to move forward there. But now I have with OCTA, I get a scan and I see something new in her scan that I haven't seen before. So what I've found in this patient, if we look at this image with OCTA, I'm looking at the patient's blood flow in addition to our standard OCT scans. So with OCT angiography, we're able to see superficial circulation as well as deep circulation. And we can't really even see that with fluorescein angiography. It doesn't segment it out like that. So in a patient that has intermediate AMD, I'm looking at that deep circulation at areas near the photoreceptors and near the RPE is like there should not be blood flow down there.
Right.
In this particular case, there's a small spot in this patient's left eye, just temporal to their fovea, where there's a drusen. You can clearly see that. But then when we look at the actual blood flow there, there's increased flow indicative of a choroidal neovascular membrane. What's so interesting about this case, and this is something that is really only seen with OCT angiography, is this patient does not have fluid in their retina. If you look at a traditional OCT B scan, that side cut,
Hmm.
there isn't any sort of dark space underneath the retina or no cystic spaces. This patient looks like they have a dry macula, which they do. But this patient actually, based on their OCTA, has something called non-exudative AMD. They have a neovascular membrane, macular neovascularization, but it's just not leaking.
It
And
is interesting, Damon. So, like, when you're looking at the different slab cuts that an OCTA gives you, that outer segment, we expect it to be void or absent of any vasculature, any blood vessels. And in this patient, you saw some blood vessels that were present there, but the reality is you didn't expect that. But this point that you're making, this catching these nets before they leak, is tremendous because even if we don't do anything different other than simply follow that patient closely, we know that with even guarded prognosis, the sooner we catch these patients, if they do start leaking, the better the prognosis is because we'll just get treatment to them sooner. Are you guys treating at all prior, or are you working with surgeons that are treating prior to a leak, meaning they see a new vasculature, they don't see any leaking yet? Will any of the surgeons begin treatment, or is it a wait and watch?
so there's actually been some studies that have looked at these patients, and it's shown that our current anti-VEGF agents really don't do anything for these sorts of patients. They treat exudation. If the exudation or leakiness is not there, there's nothing to treat. But this is kind of like a ticking time bomb when we see this. These patients, if you look at, there's a study that looked at patients that had these sorts of lesions where they're there, there's abnormal blood vessel growth, but it's not leaking yet. And they looked at patients that didn't have those sorts of lesions over a 2-year period, 13 times greater risk of converting to exudation in these patients that have the non-exudative lesions. And ultimately, about 15 to 40% of these will ultimately become wet. What is happening now is you've got this abnormal blood vessel growth that at any point could start causing leakage into the retina and cause symptoms. So what I've done now, if I didn't have this technology, is say, well, Mrs. Smith, I'll see you in 6 months. Everything looks really good. I don't see anything new. Now with OCTA, it's, hey, we have something new here. We don't need to treat it yet, but this is something that I'm very concerned could progress. It's not something that I'm going to refer out because there's no treatment indicated at this point. But I'm going to probably narrow my time interval. I'm going to probably see her back in 2 or 3 months. I'm going to consider prescribing home monitoring. I do have patients on 4C Home where they're doing this metamorphopsia testing at home,
Yeah.
utilizing AI and
Yeah.
remote monitoring. And it's really slick. And if someone progresses, sometimes technology will catch that before the patient's even aware of it. So I'm going to have her continue her supplement. I'm going to see her sooner. I'm going to think about home monitoring. And then if I see anything that looks like exudation, I'm going to recommend that she see a retina specialist to start anti-VEGF therapy. And I've had patients like this where I keep them at 20/20 wet. The patient's average in the United States is about 20/80 when they get diagnosed
Mm-hmm.
with wet
Mm-hmm.
AMD, and most people have severe vision loss. These
Mm-hmm.
patients that have early membranes that we're catching early, we can save their vision. It's just incredible the technology that we have, both for diagnostic and therapeutic for these AMD patients.
That's great. So if it does leak, the earlier you catch them, the better the outcomes, essentially,
That
Damon.
is absolutely the number one thing is what is their acuity at the time of their first injection? That's going to
Mm-hmm.
predict their success over the next 7 years. So if
Mm-hmm.
we can catch patients very early, get them treated, we have a much better chance and they actually need fewer injections over time as well. So what we don't want to do is look at this patient and say, well, you don't have any symptoms and I see some drusen and I'll see you in a
Yep.
year. It's just too high of a risk. And now we can stratify that risk even more with OCTA. Is like this patient is probably at the highest level of risk of needing treatment. Again, they don't need treatment today, but they need close monitoring by somebody that has this technology to be able to detect the very first sign of exudation if it ever happens.
That's great. Damon, as always, extremely insightful. And you always pick up a few nuggets and pearls communicating with you. Thank you so much for being on the show today.
Dr. Burzik, my pleasure as always. Take care.
And thank you all for joining us on this episode of the Optometric Insights Show.